fact, it has happened second time with us, and we need to reply this with a reason this time.
Okay.
So this is the second time it has happened, and everybody is updated about that.
Yeah.
Maybe I'll talk to you separately about it.
Yeah.
Whether we can continue or
Yeah. I mentioned the systemic sclerosis as also an interesting disease for having a profile or a disease-specific profile. So,
Jasmin, sorry. One particular thing with regard to this particular PSD, I just want to explain. In 2008 or 2009, we had a specific case where in SSA or SSP, one of the two, we had only autoimmune not being able to, I think my voice is audible. Okay. Where only Euroimmune was not being able to pick up, not only in India but across the world. And when we sent we were able to take the sample, if I'm right, I took it from Hinduja, and we sent it to Euroimmune for analysis. And we found that there was no SSA, and it was clearly shown as negative, and they cross-checked with all the different methodologies, and it was found to be SSA negative. So what Jasmin was telling was that the clinical correlation, it is not a clinically characterized sera, and that's one of the reasons why we see this happening. And this, I mean, to the best of my knowledge, I remember very well that Hinduja, Metropolis, and one more lab, 3 of the labs from India had reported negative. And we were able to pick up the sample and send it, and we were able to find out that it was negative by all methodologies, including the immunofluorescence, the line immunoassay, and the ELISA. Sorry for interrupting.
So in case of systemic sclerosis, we can differentiate between the limited form of scleroderma, diffuse form, and these are associated with different antibodies. So, and you see this is a huge list, and the most common ones are antibodies against centromeres or antibodies against SCL70. Furthermore, you can see here our RP155 or RP11, so RNA polymerase as target antigen. Then we have THTO. Then for the limited scleroderma, we have others like fibrillary. We have overlap syndromes. So also these antibodies play a role. And what you see here, this is a panel of different antigens all associated with systemic sclerosis. And as I mentioned, this is one study based on 129 clinically characterized SSC patients and 142 disease controls. You see the antibody prevalence varies, and SCL70 is the most common one with 65%, centromere protein B, the next one. And you see that there are, like for example, RNA polymerase with 5.4 or 7.0, so 2 different subunits of the RNA polymerase, have a quite low antibody prevalence. But yeah, patient can be positive just for RNA polymerase antibodies, for example. So, and if you have these panel and you cover all these, you see with this study you get a serological hit rate of 85%. So these profiling for the diseases might be quite important. Especially one thing more regarding the systemic sclerosis is it's for on one side the differentiation into different disease groups. If you, I mean, you have clinically, you see if it's probably limited or diffuse on not just on the antibodies, but another point is that you, beside this differentiation, you also can do a prognosis. And this is what I will show you on another study. This is an Australian study. They investigated 2 cohorts of patients, and they were interested in the relationship between the antibodies and the clinical phenotype. And on second, with the second cohort, they investigated the survival between different groups of patients with the specific antibodies. So based on this profiling of their samples, they found also here antibodies against centromeres, most common in limited form of systemic sclerosis, and furthermore THTO, PMSCL-KU they found in case of a diffuse form of scleroderma with 61% SCL70 and 90% RNA polymerase. Furthermore, overlap syndromes they found with 78% U1 RNP. When they had a closer look on the clinic of these patients, they found that antibodies against THTO were for 38% associated with the pulmonary hypertension, SCL70 and 30% with interstitial lung disease, renal crisis, especially for RNA polymerase. So there's a different association with a significantly reduced survival as compared with the patients with a limited form and, let's say, just centromere antibodies. So what they concluded is that there's a improvement in the routine laboratory protocol for systemic sclerosis. There was a better classification of 45% of the patients, and so they saw this as a reliable alternative. So this broad spectrum of antigens prevent of underdiagnosing the disease. And you can see then you get a prediction and an outcome, which is something you'll look at. When it comes to idiopathic inflammatory myopathies, the main subforms we see is dermatomyositis and polymyositis. And you see a huge list of target antigens. I mean, the most common one and well-known one is the Jo1. This is known for many years. But within the last decades, there are a lot of more antigen being described. And you find them mainly here in the group of the dermatomyositis. So Me2 or NXP, TIF1 gamma, SAE, for example. And we have also here overlap syndromes. We have inclusion body myositis associated with antibodies against MUP44 and necrotizing myopathy with HMG-CR. This is mainly then in patients found that are treated with statin drugs. So here are some of the new ones. So MDA5 with a higher prevalence in Asians, up to 73%. Here, in the presence of autoantibodies against MDA5, there's an increased risk of interstitial lung disease observed in NXP2. We have mainly found in juvenile dermatomyositis. Here, it's also associated with interstitial lung disease. TIF1 gamma, we have a marker which is associated with cancer. So this is a predicting marker. And again, associated with interstitial lung disease, SAE1 and 2. Yeah. So meanwhile, it is possible to cover up nearly all antigens for polymyositis as well as for dermatomyositis. Of course, the overlap syndromes, these are known markers which we have in the ANA panel anyhow. And you see, especially in blue, so Jo1 is known, PL7, PL12, EJ, OJ, these are all amino acid tRNA synthetases. So I guess the list is even longer. And the thing is, the problem is each of these antibody has a very low prevalence. And this is something you see also in these two studies here. So you see Me2 showed a prevalence of 3%, PL7 2% in these 153 sera from myositis patient. In the other study, it's a little bit higher. So the serological hit rate of all antibodies was 26 and 37%. And
there's a long list of antibodies.
yes.
I mean, which one do you, advise we should go in for scleroderma?
For scleroderma, I mean, important, yeah, centromeres definitely, SCL70, and this is what you have routinely also on the ANA.
Thank you, madam. We had a very nice, interesting discussion with you.